Good afternoon, everyone. It's a bit strange, isn't it? Recording our presentations instead of delivering them live, but here we are, and it's great that we've got a chance to get together and discuss all the things that we've been doing within this community over the past couple of years. My name is Jane O'Hara. I'm a Professor of Healthcare Quality and Safety based at the University of Leeds in the UK. And today what I'd like to do is to talk to you about briefly about some work that we've been doing locally within Leeds and Bradford during the pandemic, where we've looked to see how the public helped to co-create the healthcare system resilience of the pandemic response, and what this means for an analogy, a concept, if you like, that we've been thinking about over the last few years, which is that patients and families co-create or scaffold the resilience of our healthcare systems. So just to briefly talk a little bit about this scaffolding analogy, traditionally, I guess, patients have been seen as sitting just outside the system, that they're users of systems rather than necessarily interacting with the system or changing the system outcomes. And where they do interact with the system, this has often been seen to introduce unwarranted or unwanted variation, and those are things like non-adherence to medication or perhaps not stopping smoking before surgery. However, we're beginning to understand that patients can actually be a source of or contribute to the resilience of healthcare systems. And the ways in which that they do that are, there's a number of different ways. And I'll give you some examples here. These are being largely much more documented now in different studies. And examples of that are things like handing a letter to your primary care practitioner, your GP, when you're discharged from hospital to make sure that they understand how to manage your ongoing care needs, phoning and chasing appointments in different healthcare settings to make sure that care is delivered in a timely way, and undertaking things that have actually hitherto been seen as largely clinical, like medicines reconciliation, making sure that you have the right medication and that things that haven't been deprescribed aren't still being given to you, for example. So, as I said, myself and colleagues have been thinking about this and have come to term this as scaffolding of our healthcare systems. And by this, what we mean is that it's not just staff and services that adapt to constantly changing conditions, but actually patients and their families undertake activity that contributes to the observed or the potential resilience of healthcare systems. And we've written about this here and in another or other articles collectively. But what this means really for both this study, but for the wider issue of patient and family involvement, I guess, in the resilience of healthcare systems, is that we need to understand that patients and families co-create the safety of their care, and that we cannot know how successful our healthcare systems are without examining and exploring and documenting their contribution. So this brings me to the subject in hand, and of course this photo needs no introduction. Like many researchers and clinicians in our resilient healthcare community, when the pandemic hit, we started to witness in real time health services adapting and changing to this most significant of disruptions. And like everyone, we were anxious about what was happening for ourselves, our families and our research teams. But we also knew that we needed to document these expressions of resilient performance in order to understand their effectiveness and in order to adequately plan for the future. So in the UK in late March, as we started to see patient admissions for this new disease creep up, it became evident that this new virus would cause incredible disruption to normal healthcare delivery. And like many of you, I'm sure, we witnessed staff and services making many immediate and ongoing changes to the way in which healthcare was delivered. But whilst much of the discourse focused on adaptations of services and staff, we also recognised that users of services were being asked to adapt their behaviours, sometimes with the explicit or express intention of saving lives and helping to minimise the disruption on health services. to put it simply, really, every one of us was asked to adapt our behaviours as part of this global public health effort. And this, we felt as a research team, could well be a really perfect expression of this scaffolding role. So what we did was to instigate locally a series of studies that would document and explore how people using healthcare services also adapted their behaviour alongside the adaptations we were witnessing in services, and that these adaptations by patients and families would help to keep themselves safe and keep others safe. So we set up a 3-armed study with 3 groups of people. The first group was people who were actively receiving breast cancer treatment and care. The second group was what we termed seldom heard voices, and for this group we sampled, this work is ongoing, we're working with people within communities such as homeless people, refugee communities and South Asian women. But the final group, or perhaps the first group, because this was the first group that we studied, were members of the public, and it's this group, the results from this group, that I want to share with you today. So we wanted to understand how the public's experience of supporting their safety changed across time. And so we instigated a longitudinal interview study with 3 time points across 6 weeks. So there was an initial, perhaps longer interview that was then accompanied by 2 slightly shorter follow-up interviews at 3 weeks and 6 weeks, respectively. We recruited via adverts placed on Twitter, and all interviews were conducted remotely via Zoom. In total, 21 members of the public participated in 57 semi-structured interviews across these 3 time points, and this work was conducted between June and September 2020. We initially analysed the data inductively, and we adopted a within-person approach and produced in-depth summaries of our initial impressions for each participant across these 3 time points. So we had a sense of people's journeys across these 3 time points and across that initial part of the pandemic. And from this analysis, we've come up with 3 key themes that consider the role of the public in co-creating the safety of their pandemic response. And these themes are what we're describing as the new safety normal, exposing fault lines, and finally, are we all in this together? So this first theme we have termed the new safety normal. Sudden adaptations were made by health services in response to the coronavirus outbreak, which caused an enormous ripple effect, which was felt in participants' daily lives. And simple daily activities that were never really viewed as safety related previously were now suddenly considered via the lens of risk in efforts to reduce virus transmission for others or indeed for themselves. And individuals also referred to a sort of continuous re-evaluation of how both they interacted with health services based on perceived preparedness, but also how they navigated potential threats that were posed to their safety. And the first sub-theme within this wider theme we've termed feeling cast adrift. And this is because lots of people told us that where they were regular users of healthcare services, they reported feeling cast adrift. People that were using both physical and mental health services were suddenly left to independently monitor and make decisions about their care and the safety of that care. Participants described having to do much more of the usual scaffolding activity, such as chasing tests or chasing appointments and coordinating their care, than they had to do normally or certainly pre-pandemic. And this activity was made more difficult by the constant service adaptations and the changes to services, where sometimes perhaps services were made available to patients, and then sometimes within a matter of days or weeks, they would seemingly be unavailable to patients. And those receiving mental health care felt these changes most acutely, with some services just suddenly unavailable, which effectively cut off their usual lifelines of support. The second sub-theme we termed adapting to support. And this was to describe the fact that people reported making very immediate and ongoing behavioural adaptations. Many people were particularly reluctant to access health services unless they perceived it to be absolutely necessary. And this was due to both a perceived increase in risk of contracting the virus, of course, but in many cases was simply to help the NHS cope with the additional strain, which is very evidently a way of trying to mitigate the worst outcomes for healthcare services. What was interesting, I think, though, was perhaps an unintended positive consequence of these adaptations was that where people were engaging with services or had no choice but to continue to engage with services, they actually told us, particularly in those first phases, of the amazing care that they received because more staff were available, and actually there was reduced activity, meaning that care could be delivered in ways that staff would perhaps ideally normally want to or be able to provide. The next sub-theme was we've described as balancing risks. And what was really interesting, I think, in terms of this being potentially a resilience expression was that all participants expressed a continual trade-off between protecting their physical and their mental health. But what was interesting was that engaging behaviours to protect their physical safety was sometimes detrimental to their emotional well-being. Initially, for many participants, their original priority in the early phases of this work was to protect their physical safety by staying indoors, staying home and using virtual alternatives to either shop or socialise or see family or friends. But as time progressed, the prioritisation of physical safety perhaps lessened for some, and concerns about mental health grew, which were fueled by a sense of monotony or isolation or loneliness. So you can see that actually the ways in which people were making these trade-offs changed over the course of the pandemic. The second key theme we termed exposing fault lines. And for some, the new safety normal was not really new at all, but rather exposed to others and perhaps themselves the daily battles that they had to scaffold their care and to ensure their own safety. And the pandemic both exposed this existing scaffolding activity, but also the vulnerabilities of some people and some groups. And our findings actually suggest a significant safety paradox, if you like, that people with existing vulnerabilities were more likely to experience considerable safety gaps in their care and be required to step into larger gaps to scaffold their safety, despite it being more difficult for them to reach in and for them to do so. And one of the key issues is what we are terming safety capital. And this really describes the ability of people to reach into the system to support themselves was dependent on their capital, their resources, meaning that for some, they could support themselves much more easily than for others. And an example of this was the fact that participants who lived in less rural areas where it was built up areas, or where people didn't have perhaps a car to get around or access to a car, they felt really trapped indoors, and that they had to walk through busy streets with lots of people, or they had to use public transport to access healthcare appointments, or where to access green space or leisure activities to help maintain their physical and mental health. And we also saw huge inequities in healthcare or information access, and that these things were dependent often on culture, on language, or clinical vulnerabilities, which all provided barriers to supporting safety. So paradoxically, those deemed most vulnerable, such as those with pre-existing health conditions who were asked to shield, were often required more to leave the safety of their homes to access healthcare services. So whilst the safety gaps for everyone increased, for those who were most vulnerable and with the least safety capital, those safety gaps widened the most and were perhaps the most difficult to close. And the final theme that we came that emerged from our analysis was something that we're calling "Are we all in this together?" And there was a general sense of empathy for how difficult others' circumstances were during the pandemic, and that that actually we needed to contribute together to the societal efforts to flatten the curve. But what was really interesting from our data was actually that this feeling of sort of a societal effort to mitigate the worst of the pandemic and to support healthcare services, this really changed over time. And people described suddenly monitoring situations for safety that they had previously not thought about. Everyday activity now required monitoring for its safety risks, and for some, this was a burden that they felt very keenly. What was interesting was that at the first round of interviews, there was a general sense of empathy for how difficult other circumstances were during the pandemic, and that we all had to contribute to this societal effort. But actually, over time, differences in people's approaches to risk and safety were highlighted, and in particular, this was related to the government's response, the official guidance, and the signals that we were getting as members of the public about how to monitor our own safety and how to help support the pandemic effort. Monitoring safety requires, obviously, a variety of information and signals, and trust in these signals is therefore crucial for people to act positively and respond in ways that help keep them safe. And we did see this trust in these signals change over time, and it did impact on the ability of people to adapt their behaviours to maintain safety. Many people reported distrust in the government and their guidance over time. And what was interesting is that people over time spoke about muddling through with the sense that nobody really knew what the best approach was, even those setting the actual official guidance. But what this meant was that people felt even more anxious, as they felt that the information that they were using to make these decisions about managing their safety and the safety of others and their level of risk was not trustworthy. And so they didn't necessarily know how to optimise their safety and well-being. So what does this all mean and why is it important? Well, the first thing to say here is that this analysis is still ongoing and we are still trying to make sense of what it means for the roles of service users and users of physical and mental health services in terms of system level resilience. We did initially go into the data analysis deductively to look for examples of how people were undertaking activity which would be commensurate with the four resilience potentials of responding, learning, monitoring and anticipating. But I'm sure, as you have heard, you might agree that lots of what we've explored doesn't necessarily sit neatly within this framing. And so over the course of the analysis, we discussed how this approach didn't necessarily fit with the totality and the richness of our data set. So I'd be really interested to hear others' ideas about what these data might mean for resilience theory and practice. But I do feel at this stage of this analysis, we are able to draw a number of conclusions. The first is that the public co-created the pandemic response without a shadow of a doubt, but that for many people, actually, that this was an unexpected burden and something that wasn't necessarily articulated, that there was a sense of chronic unease and that this safety work was a real burden and that this burden was unequally experienced by members of the public, and that the pandemic really served to expose the fault lines in our existing services, but also the existing scaffolding role of patients and families. So in terms of implications, we've identified a number of important takeaways from this work. And the first is that, as I mentioned at the start of this presentation, but perhaps hopefully reiterated during this presentation, is that we need to acknowledge the safety work that patients and the public undertake in order to maintain their own safety, but also the resilience of healthcare systems. We need to document and learn from this experience, and we particularly need to understand and anticipate inequities in pandemic and public health responses, and we need to plan to mitigate against those things. So thank you for listening to me today. I hope this has been interesting, and I look forward to a discussion.